Good afternoon. I'm Dr. Anjali Sadhwani, and I'm thrilled to be here with Dr. Ann Wheeler and Chris Carey to present to you the Behavior and Anxiety panel. I'm just going to provide you with an overview of the session. We're going to be talking about challenging behaviors in Angelman syndrome. We're going to go over both the behavioral and medical strategies to help some of these challenging behaviors. And for that, we're just going to provide an overview. And then we're going to go into detail of 4 behavioral concerns that we've found commonly addressed in the community. These include anxiety, aggression, irritability and hyperactivity, and sleep. And then we'll open it up for discussion and questions. We know that behavior problems are common in individuals with the Angelman syndrome. They interfere with their ability to interact well in the social environment. The frequency and severity of behavior problems differ based on molecular subtype. Behavior problems are often a source of stress for caregivers and impact family quality of life. So what are the most common behavior problems? This slide shows data from the natural history study. The data differentiates behavior problems based on molecular subtype. The orange is deletion, the blue is UPD unprinting, and the pink is UBE3A mutation. As you can see on the graph, the behaviors range from the highest frequency to the lowest frequency. So mounting behaviors are the most common and temper tantrums are the least common. When we look at the behaviors that we are going to be talking about specifically, anxiety, we notice that kids with deletion would have less anxiety than children with non-deletion. Similarly, in non-deletion, aggressive behaviors are more of a challenge than those with deletion. On the other hand, when we look at hyperactivity, there are no differences between deletion and non-deletion children, and there's a high frequency of this behavior. Similarly, for short attention span, there's a high percentage of all individuals, irrespective of molecular subtype, who have attentional challenges. In addition to these behavior problems, we notice that sensory concerns are a huge problem in our community. This includes tactile defensiveness, resisting touching of the head, resisting objects placed on their head. And we notice the prevalence and frequency of these behaviors are more common in individuals with deletion compared to those with non-deletion. So we first talk about behavioral strategies to help some of these challenging behaviors. When we look at behavioral strategies, one of the first things we need to do is take a step back and examine why the behavior is happening. We need to remember that all behavior serves a function. There are 4 common functions of behavior, especially those of challenging behavior. One is escape, that is to get out of the situation that you don't want. Attention, to get the attention of a caregiver or a significant other whose attention you're not getting. To get something tangible, such as a cookie in the cupboard or your iPad. Or sensory, to seek some sensory sensation because it feels good, or to avoid a sensory sensation because you're overwhelmed. When we looked at data from the natural history study and we asked parents the purposes of the disruptive behavior, we found that a lot of time, as much as 57% said, communication was one of the main reasons why the disruptive behaviors were happening. This was followed by attention seeking and then craving sensory input and then avoiding a situation. It is really important to understand the functions of a behavior. And that's why one of the first steps we do is do a functional behavior analysis, which is called an ABC. The A is to understand the antecedents of the behavior, the triggers of the behavior, when it happens, to understand the context of the behavior. B is to understand what the behavior looks like, how often it happens, and how long it lasts for. And the consequences are what happens after the behavior. In this table below, I'm going to talk about 2 examples for you. The first one is at school, where the teacher gets out some learning material. The child gets angry and then starts throwing material. We want to understand what he's trying to say. He's trying to say, this is too hard for me. I can't do it. What happens after that is the A takes the child up outside the classroom. When we try to understand the function of the behavior, we realize it is escape. The child wanted to get out something that was really hard. The next thing is a community outing to watch the 4th of July parade. As a child is going there with their family and gets out of the van, he gets out, he freezes, he doesn't move. He's scared of the loud noises. And what happens then is you wear the noise cancellation headphones to help reduce some of that fear. And so the function of the behavior is sensory. Once we identify the function of the behavior, we want to think about more appropriate strategies to help with this behavior. For example, if the function is to get someone's attention, you want to ignore or redirect undesirable behavior. You want to give attention to desired behavior, and you want to teach and reinforce appropriate attention-seeking behaviors. If the function is to escape, you want to give the individual frequent opportunities and breaks. You may want them to request them to teach breaks through the ASC. If they have to escape a situation, you want to provide them choices that you can either do this or this. And sometimes it's appropriate to escape a situation or limit the time a person is exposed to so that he gets a break from it. If the function of the behavior is communication, you want to be able to figure out different ways to communicate. It's really critical that your child has exposure and uses an ASC device consistently. You want to make sure the ASC device is available and accessible at all times, and it's integrated in the individual's life. If the function is sensory, you want to work with an OT to identify appropriate calming inputs. To deal with sensory aversions, you may want to use noise cancellation headphones so that the sounds don't feel as loud, it's less crowded. If there's sensory seeking behaviors, such as mouthing, you want to be introducing appropriate chewy toys. There are additional environmental modifications that you can implement so that we can reduce some of these challenging behaviors. One of the things I think individuals with AS thrive on is having a consistent routine, using a visual schedule so they know exactly what happens when. Timers are really helpful, especially if they have to work for a specific time, and when the time goes off or the timer goes off, they can get a break as needed. First and then boards have worked really well. First, we finish this, and when you're done, you'll get a reward or a preferred item. And it's really critical to plan for transition so the child knows what's going to happen. It's often very helpful to get a behavior specialist or a BCBA involved if the challenging behaviors persist and cannot be controlled.
Let's take a minute maybe now to also talk about behavioral things that can also be addressed by medications or medical issues. It's generally a good idea when thinking about a treatment plan for behavioral concerns in kids, teens, and adults with Angelman to be thinking about behavioral interventions first. If these things aren't helpful, we'll talk a little bit about medications and the role they can play as well. You can move on to the next slide. Thank you. I try to make sure I don't forget about sources of discomfort or pain that can result in behavioral change. This is a really important thing for us to be asking ourselves about. Could this be a contributing factor in kids with Angelman or adults with Angelman who may not be able to describe physically what they're feeling? I've identified a couple of issues here on the side of this slide, which are all more common in Angelman syndrome, and I've all seen as causes for a behavioral change that was really due to this source of discomfort. I've written here insufficient sleep, and this is kind of a tricky one because, of course, many kids, teens, and adults with Angelman have major challenges with sleep, and they kind of always have. But for some, there is a significant change in sleep. It may suddenly worse or suddenly change in some way, and that may coincide with the behavioral change. If that's the case, then it's worth looking at are the things that could help with that new sleep problem that coincides with the behavioral change that may actually help with behavior during the day. Constipation, it feels like that is the most common circumstance where you have a source of discomfort that's resulting in a behavioral change and we're missing it, especially because many of the treatments that can be helpful for behaviors, which we'll talk about, can cause constipation. So I try to really ask myself about this one. If there's a clear pattern where it's been a couple days since there's been a bowel movement and the behavior is worsening in that time, there's a large bowel movement and then behavior is much better, then constipation could be a contributing factor. Esophageal reflux is an easy one to miss as well, looking for things like signs of discharge on the pillow, increased drooling that is more after meals with acidic food in them, or arching in the back specifically after meals. All of these things might suggest gastroesophageal reflux being present and might make it worth seeing a gastroenterologist to sort of rule this out, or asking the pediatrician or primary care doctor. Mood changes that come with the onset of menses or in the 2 to 3 days prior to the onset of menses, could be pain related to menses or mood changes related to the fluctuations of hormones that happen at that time. This is a really common cause of behavioral concern. Look for patterns that coincide with menses to see if that plays a role. We've got to be thinking about dental problems that are more common in Angelman. It's harder to get routine dental exams. Someone might have a major problem with their teeth causing pain. Scoliosis is more common in Angelman. It's another good thing to look at. And then more rarely, you can see periods of confusion or agitation that happen after a seizure. This post-ictal confusion or sedation can result in behavioral problems. So also important to think about. Next slide. I think about these particular areas as being red flags to consider when it may be worth considering a medication is added to a treatment plan. Again, I like to start with thinking about behavioral interventions first, just as Anjali was talking about here. But if you really have given that a prolonged period of time, we might say over a period of months, 3 to 4 months or longer, and are not seeing any improvement, then we may think about a medication in that situation. If there's a real concern about how safe the home situation is, and a real risk of injury towards siblings, or the person with Angelman syndrome themselves is at risk because of the severity of their dangerous behavior or self-injury, where no amount of preparation can make a community trip safe, and it results in a very bunkered life where you can't go places or have new experiences, that's worth considering a medication. If someone's not going to be eligible for daytime structure, day programs, or staff coming into the home, and parents have to provide 100% of structure because it's not safe to do it any other way, that's a very reasonable situation to think about use of medications. And if it's not safe to place any demands, all of us need demands in order to make progress in our lives. It's really important to make progress in speech therapy, physical therapy, occupational therapy. So it needs to be safe to put these demands in place for people to make progress. So some situations to think about.
Okay, so as Dr. Swani had mentioned at the beginning, we're going to now go through 4 behaviors that are pretty common in Angelman syndrome, and we'll talk a little bit about what types of medication and non-medication strategies might work to address that issue. So Dr. Curie and I are going to tag team these. We'll go back and forth here. So next slide, please. So starting with anxiety. So anxiety is an interesting topic because it is considered to be highly prevalent among individuals with Angelman syndrome. However, the way we think about and measure anxiety is really thinking about this as an internal experience in which an individual feels anxious, nervous, scared about something. And often when we're measuring anxiety, it requires that a person can tell us what it is their internal experience is in order to be able to determine whether or not this is anxiety or something else. And so, as we all know, with our patients with Angelman syndrome, the ability to verbalize what their internal experience is not something that they are typically capable of doing. And so we really have to sort of make some guesses about what anxiety what behaviors might be occurring that we think may be stemming from anxiety. And so we've done a lot of work on this, thinking about it, as well as asking families about what anxiety looks like for them. And so some of the things that families may say, anxiety looks like irritability. It looks like agitation. I know that when my loved one with Angelman syndrome is anxious, they become more agitated. They become more restless. They may engage in more repetitive or ritualistic behaviors. There may be increased screaming, increased crying. And then there also could be things that we often attribute to anxiety, such as somatic issues like sweating or having stomach pains or vomiting or shaking. So it could range from any of these things. And then next slide. Some of the sources of stress or anxiety that cause some of these behaviors that are attributed to anxiety often are things like leaving a parent or a preferred caregiver. And we tend to see this happening as individuals get older, like in later adolescence and early adulthood, when they're transitioning out of a school setting. We see an increase in anxiety around being separated from a preferred caregiver. It could be that it's when they're going someplace new or someplace that they weren't expecting to be, and it's a new environment that they have to figure out and learn about. when they're asked to do something that is outside of their range of abilities. And this could be, an academic demand, which we may be asking kids to do outside of their scope of ability, but it also could be something behavioral, like I need you to just sit and be quiet and pay attention for a few minutes. And that may just challenge their actual ability in terms of their attention span. Often when there's too many things going on at once, all of us might feel anxiety around that type of situation, and we can expect that may be something that is also being experienced by individuals with Angelman as well. And then there can be sensory issues that can increase our arousal levels and also induce anxiety or anxiety-related behaviors. And these could be like loud sounds or too many competing sounds. It could be smells, even smells that are enjoyable, but certainly smells that are not enjoyable. And we know that individuals with Angelman do have some difficulty with temperature regulation. And so if the temperature is too hot or too cold, this could also spike some anxiety. Next slide. And so we really need to think about what might an individual with Angelman be saying when they're appearing to be anxious. And so these, again, we don't know. We can't go inside their bodies and feel what they're feeling. So we have to make a guess based on what we see and what we know about the individual. So if an individual is showing these behaviors and it's perceived to be anxiety, it could be because they're worried about not having somebody that is safe nearby, that their parent is not going to be there and know that other people won't know how to take care of them. They can get scared when they don't know what to expect, when their demands are too high. They're worried about what's going to happen or what might happen if they don't do the right thing. Again, if the environment is crowded or noisy, that may make them feel stressed and have a higher threshold or lower threshold for additional stressors coming into their environment and increase the behaviors and the anxiety. It could be that they're uncomfortable, or they have associated previous discomfort with a certain situation. And this we see a lot when we're going to the doctors, if there's going to be a shot involved, that even just the building or the word around going to the doctor could increase anxiety and stress, and we may see some of these behaviors come out. And it just could be really a general feeling of, I don't know what's going on, something doesn't feel right, and I don't know what to do about it. And so I'm going to act out in these ways to try to get somebody to help. Next slide. So between the three of us here on this call, we've done quite a bit of work trying to understand anxiety in Angelman syndrome. So Dr. Curie here did a study where he looked at multiple different types of measures of anxiety to see, what the most common concerns are, and things like being separated from a loved one, or aggression when it's being both types of scenarios in which we are hearing reports of additional anxiety increases. And then we did a study at UNC a while back where we asked parents just to describe what kind of anxiety they're seeing, as well as this phenomenon that we were noticing in the clinic, where there would be older individuals that were showing the separation distress from a common caregiver, from a preferred caregiver. And we did this. We looked across the different subtypes also to see if we might see some differences. And you can see that we do see high levels of anxiety concerns, and that these were most prevalent in the UB3A mutation subgroup. And that the anxiety concerns were often related to that caregiver preference, not wanting to separate from a caregiver, or feeling agitation if they feel like somebody's going to come in between them or something's going to happen to reduce their access to that preferred caregiver. And this contributes to the caregiver's fears. So when a caregiver is worried about walking away from their loved one with Angelman, even just to go to the bathroom or go out to the grocery store, that increases the stress for the caregiver. And it can be a cyclical thing within a family. If both individuals are stressed and anxious, then they can feed off of each other and increase anxiety for both individuals. So we want to present a little case study here about Alice, and I'm going to pass the baton back over to Dr. Curie to talk through this one.
Thanks so much, Anne. So yeah, let's talk about some cases. So Alice is a 20-year-old woman. Her mechanism of inheritance for Angelman syndrome is a maternal deletion. And the main concern that the family has is that they think that Alice is having separation anxiety. Alice has a close relationship with her mom. And whenever there's a sense that Alice has that mom might be separated, they see some really challenging behavior, which they think is anxiety. This could be nervous laughter, hitting, biting, and behavior that is very hard to ignore. Throwing things, property damage. Clinicians have told them to try and ignore the behavior. It's not really ignorable because it causes real property damage. It's very effective in pulling in the attention of the family. And circumstances where it happens that give them the sense that it's separation anxiety is if there's a clinician that comes to the house that's going to work with Alice around physical therapy, or they've tried to get behavioral clinicians come into the house to work with Alice. And if Alice has the sense they're coming in and mom's going to leave, then that's a real no-go. And they see a lot of this agitated behavior. Mom's got to kind of sneak out of the room, or Alice has to be distracted in order for that separation to go well. Alice does great when it's one-on-one with her, with mom. None of these behaviors at all. It's that anticipating separation where they see this behavior occurring. Next slide. I think I pass it on over to you again, Dr. Wheeler.
Yep, sure. So, we talk about different types of approaches that may work for Alice. And the first thing we want to do is make sure that there aren't any medical contributions, as Dr. Curie had noted. We want to rule out anything that may be going on physically that we need to address before we focus on behavioral issues. And then another strategy for Alice might be engaging with her occupational therapist to develop some sensory interventions that could help calm her, so that when we start to see this agitation ahead of the service provider coming in, or ahead of a situation which we know we're going to require some separation and require some it may involve more agitation, that we want to have some calming and sensory interventions that can be used to help reduce those behaviors. Communication, wherever we can help the individual communicate in a different way other than engaging in the behaviors, that's what we want to do. So trying to teach Alice to use her AAC device, to be able to request a preferred family member, request her mom, and then we can start to work with that. We can do an if-then board to say, after we've done this, then we get to have some special time with mom, as an example. Some additional strategies that could work for Alice would be to make sure that there's a nice ritual where it's clear to her that this is the time of separation, and the time of reunion will come right after that, after she does the work with wherever she's going in terms of the separation. Sometimes individuals can be soothed by having a video or a picture of a preferred caregiver. This depends on the individual. In other cases, that might backfire. If the individual sees the picture, then that may start to remind them that the individual isn't there. So that's really, it just depends on the individual and what might work. Desensitization therapy, or sort of gradually exposing an individual to a fearful stimuli. So, maybe this means that mom is in the room, but on the other side, or on the other side of the door first, and then gradually starts to move further and further away the more she has success with having some space away from the individual, away from the preferred individual. And then some individuals really do well with things like social stories. So talking about what's going to happen when in a story that gets repeated frequently. So allowing the individual to sort of see the story. Okay, Alice has this person who comes, and during this time, mom goes and does her thing, and she's over here and she's thinking about Alice, and Alice is thinking about mom. And then at the end, when they come back together, everybody's happy. So, to provide a story, and again, needs to be repeated multiple times in order to help the individual sort of understand that this is what's going to happen. You can also use fear of missing out to your advantage, making environmental changes to help the individual think about like what's going to happen, and when will be the next thing that I get to do. So there's lots of different types of non-medication strategies, different types of behavioral strategies we can employ to try to help reduce that anxiety. And now we'll talk a little bit about some medication strategies that might work.
Yeah, definitely. That the FOMO thing, I think oftentimes my experience is that the separation goes better if you're going where the party is with going to somebody who is interactive and social and around the same age, and there's a kind of like, I'm going to where the fun is, and that can help with the separation more than being left behind, if that distinction makes sense. But a lot of these interventions, if they don't work, it's worth thinking about medications. When we think about treatments for anxiety, oftentimes from a medication standpoint, we think about serotonin. Many of the medications that help with the treatment of anxiety disorders involve increasing serotonin in the brain. Serotonin is one of the neurotransmitters, neurochemicals that all of us have in our brain. It seems like medicines that increase serotonin help with anxiety disorders, things like panic attacks or generalized anxiety, or obsessive compulsive disorder. So these are reasonable medications to think, and have been helpful for some individuals with Angelman who struggle with anxiety. Buspirone is kind of unique among medicines that work in serotonin because it's got a mechanism of action that's a little bit different than your Prozacs and Celexas and Zolofts of the world. This sort of mimics serotonin and activates the receptors in the brain that bind to serotonin. It kind of mimics serotonin, and that appears to be a mechanism of action that's really well tolerated. So it's a medicine that's oftentimes used in kids, people who are sensitive to medications, and appears to be well tolerated for people with Angelman who can be a little more sensitive to medicine side effects. So it's a good place to start oftentimes. Then we might have the next step be things like traditional antidepressant, anti-anxiety medications. These are like Prozac, Celexa, fluoxetine, Zoloft. These medications increase serotonin by fooling the neurons into thinking they haven't released any serotonin yet. And then it's also worth thinking about as-needed medications. You know, it's nice if we can avoid an everyday medication. So as-needed treatments that are used around a situation around separation or anticipated separation can sometimes help. These common as-needed medications for anxiety, benzodiazepines, these are medicines like lorazepam or Ativan, clonazepam or Klonopin. These medications are used a lot in Angelman syndrome for control of seizures. They're like your class of medications used to break a seizure. Some people with Angelman take an everyday dosage of it to prevent their seizures, and they can help with anxiety as well. They're treatment for panic attacks, essentially. And then we have propranolol. This is a medicine that's called a beta blocker. So it does the opposite of what like adrenaline does in the body. We think about norepinephrine and epinephrine. These are stress hormones that are released during the fight or flight response. And beta blockers do the opposite of that, or block the effects of those stress hormones. And so in this way, they can be calming. This is a common treatment for like stage fright or people who have got performance anxiety, and they can be helpful on an as-needed basis. All right.
Okay, moving on to talk a little bit more about aggression. And of course, this aggressive behavior can be seen as a response to anxiety, but really focusing in on how do we address the specific aggressive behaviors. So just a little bit of background. We do hear quite a bit of about there being aggressive behaviors in Angelman syndrome, and there have been studies that have indicated that this may be even higher than in some other genetic syndromes that cause cognitive impairment and challenges with communication and motor, similar to Angelman. And so two examples from the natural history study data of the types of aggressive behaviors and how we see them sort of manifesting across the different molecular subtypes. One would be explosive behaviors. So these are about half of the individuals with Angelman syndrome will be described as having explosive behavior. And this is more common in our non-deletion subtypes than in the deletion subtype. Another common behavior is throwing objects. And again, we see this much more common in the non-deletion subtype groups than we do in the deletion subtype groups, although up to 40% are also of the deletion kids are also endorsed to have throwing objects as a high aggressive behavior. And these behaviors do seem to increase as the individuals get older. This is especially, as we note, is more common in the non-deletion subtypes as well, and that tends to continue to increase over time. So here on the left side is changes in irritability, and this is from one measure called the Aberrant Behavior Checklist, where we're looking at how much irritability types of behaviors are increasing as an individual gets older. And you can see that the solid line is the deletion subtype, and we see a lower rate of irritability at the beginning when they're young, and that it goes up a little bit as they get older, but not as much as we see with the non-deletion subtype groups, especially with UBE3 mutations, where we tend to see more irritability as individuals get older. Here on the right is one specific type of aggressive behavior, which is pinching, that we often hear of as a challenge for individuals with Angelman. And again, we're seeing increases in these behavior, in the likelihood that an individual is going to show pinching behavior as they get older. And this is true for all three groups, but especially for the UPD and imprinting center defect group. Next slide. Okay, so our case study here is CJ.
CJ is a 32-year-old man with Angelman. His mechanism of inheritance is uniparental disomy. And the main concern here are bites and pinching and some of the behaviors that we just heard Dr. Wheeler talking about and Dr. Sadhwani found in her research. There are a couple of different circumstances where CJ has these, if we want to use the word aggressive, some families will use other words for that, but use other terms for this. But the most common scenarios for CJ, first one was a non-preferred demand, a transition away from something that CJ really likes to something that is less preferred. So leaving the pool, getting out of the car, being prompted to work on a particular therapy or do activities of daily living, teeth brushing, things like that. Any sort of transition from something CJ likes to something non-preferred, they'll quickly see this behavior. And it might come with a big shout and explosive reaction, maybe even flopping to the ground, making community trips very hard with a 32-year-old man. So increasingly, it's really not safe to take CJ to the places he likes to go. Another circumstance where they'll see aggression in CJ is those kind of things that sound like anxiety that we talked about in our previous case. This visitor comes to the house, even family, like extended family coming to the house, and that's made the parents for CJ feel that CJ may be anticipating somebody asking something non-preferred of him or taking the attention of mom and dad, his preferred, his people. So whenever there's a non-preferred caregiver, it's been very hard to get caregivers coming to the house to provide some daytime structure for CJ. And then the third precipitant or antecedent that comes before aggression is no demands on CJ. Families just going in for a hug and a nice hug for CJ and a nice social moment. It's almost as if CJ is getting overstimulated or overexcited by that closeness and that sort of like affection, which he totally loves. He's laughing, he's excited, then quickly it moves to a bite, almost as if he's overstimulated by the whole experience.
Yeah, and I want to also just note that even though we see high rates of aggression in Angelman syndrome, when asked about the behaviors and when behaviors are observed, it's almost always not an intentional aggressive act to hurt. So, we do see in some other situations where an individual might be acting aggressive and the intention is to hurt the other person. That is not what we see with Angelman. It's most likely primarily more reactive, right? So as the example of CJ getting hugged, it's a sensory issue, and this is a reaction to being overstimulated in a sensory way, or it's lack of communication and trying to find new ways to get attention in order to communicate a need. And so when we think about that is important for how we might address some of the behavioral concerns. So as with anxiety, the very first thing we want to do is make sure to rule out any kind of medical contributors to aggressive behavior. So in a thorough evaluation, let's make sure there's nothing physical that is triggering the behaviors. For all of the types of behaviors, having a toolbox of sensory interventions that can sort of help with calming, regardless of why an individual might be hyper aroused and engaging in the behaviors, having some calming activities that can sort of reduce that arousal and help them with regulating, that can also reduce those aggressive behaviors. And then, wherever we can, teaching communication strategies that give an alternative way to communicate a need than pinching or grabbing or biting or hitting. And so these could be teaching how to request a break. So when they need something, when they need to step away from an activity, there's a way that they can express that without, again, the aggressive behavior. Or being able to request a preferred item that then you could set up to say, okay, we need to do one more task, and then you get this preferred item. Teaching other ways to engage an individual. One thing that I've seen successful with some families is teaching things like butterfly touch versus bear touch, or butterfly hug versus a bear hug. So really giving them more opportunities to learn ways to engage even physically with another person that doesn't lead to some sort of aggressive outburst. And then, as we talked about previously, anytime we can use some sort of schedule or some sort of visual cue, in addition to the language that we give them, to help sort of break down the expectations and the transitional needs, that can help also with reducing those behaviors. So the most, when we're seeing behavioral concerns, as Dr. Subwani had brought up previously, we really want to try first to identify the function of the behavior. So some of the examples that we've given with CJ in the strategies we've talked about, really think about the function as being communication potentially, or sensory issues potentially, but really sort of identifying what's happening right before these behaviors. And can we come up with some strategies to reduce anxiety, or or increase expectations, improve knowledge for CJ about what's going to happen next? Then we may be able to reduce the behavior. And then we also want to look at what's happening after the behavior. So we want to see, like, what are the consequences of that? If when when somebody's coming to the house and CJ throws a tantrum, and that person then no longer can do what they have come to the home to do, then CJ sort of won that battle, right? The consequence is that he escapes from whatever he was being asked to do. And so we want to think about that too, and make sure that he is getting reinforced for the right behaviors, and not reinforced for the behaviors that are problematic. And, again, similar to what we talked about with having different social strategies for how to touch, we can think about, making sure that people who might come in for a hug, where that might be a higher level of sensory input that then may result in biting, that we make sure those individuals know we're not hugging right now. We can do a fist bump, we can do a high five, we can do some other way of engaging CJ, but let's not do hugs because that's a little too much for him right now. And that's usually it has always, or at least historically, been a reasonable thing to ask, but I think even after COVID, that's an even more common and socially acceptable way of engaging with an individual. So new things to try. Okay, medication options.
It's because it can be kind of hard to know what's the antecedent sometimes for aggressions, or sometimes there are multiple antecedents. Like in CJ's case, it's reasonable to start with a treatment that's helpful for anxiety. And I've certainly had patients where a treatment for anxiety, I mentioned Busprar earlier, reduced aggressive behaviors. And in fact, the study that Dr. Wheeler talked about, where we asked families, what are the behaviors that make you think that your loved one's having anxiety? Aggression was the most common one that was cited. So it's still reasonable to start with thinking about treatments that can be helpful for anxiety. Next point here. So Busprar, and next point here. In less severe cases, I think about starting with treatments that are helpful for anxiety. These are all medications that I told you about when it comes to the treatment of anxiety. And they really are reasonable places to start. Sometimes I'll even think about benzodiazepines or propranolol, as I mentioned, as needed medicines to be given in a dosed fashion, maybe at a specific time of the day where I know that there's oftentimes aggression or things are harder, like on the return from school, for instance, or when transitioning to a new day program in an adult, for instance. So these are all sort of milder places to start from a medication standpoint. It's really nice to have somebody in kind of a behavioral therapy as well, because ideally they're taking some data on the frequency of these behaviors. For more severe cases, it's reasonable to think about medicines that are used more in the autism world. These are medicines that are used for the treatment of irritability, problems with explosivity, like Dr. Sadhwani found in her research, these quick emotional changes that are very intense, progressing to anger or very severe anxiety, where the emotional change is so intense that it's hard to teach a skill. It's hard to make a behavioral intervention because we're in full-on meltdown mode. And these medicines, they help with the quickness of mood change. Some of them are actually anti-seizure medications. So that can sometimes be a win. You've used a seizure medication, it helps with controlling seizures, it also helps with mood. And these are some of the more common anti-seizure medications that have, in our experience, been helpful for mood. I'll just make a comment on valproic acid, which sometimes that's Depakote. It's not the best seizure choice for patients with Angelman syndrome. You can see worsening in motor function related to that. On the other hand, some people's motor function in Angelman is pretty good, and they can handle a medicine like Depakote. But that's harder for somebody who has major motor impairment as part of their Angelman syndrome, major problems with walking that might make them less stable. So, it's something to think about based on how someone's Angelman manifests. And then the typical medications used in the autism world are antipsychotics, risperidone, aripiprazole, which is Abilify, quetiapine, which is Seroquel. These medications can be very helpful for very severe aggression with real emotional explosivity. And it's just important to watch for appetite increase, to watch for muscle twitches or movement changes or constipation with these medicines.
Okay, moving on to hyperactivity and inattention. And these are two different types of behaviors that often are talked about together because they're part of a cluster of behaviors that are associated with the diagnosis of ADHD, or attention deficit hyperactivity disorder. We're going to talk primarily about hyperactivity, knowing that inattention is also a part of this. So there have been several studies that have looked at hyperactive behaviors in individuals with Angelman. The most robust and recent one is one that Dr. Anjali Sadhwani here on this call led. We're looking really at hyperactive behaviors over time, and found a high percentage of children with Angelman syndrome are reported to be hyperactive, and that there does seem to be some evidence of an increase in the severity of hyperactivity with age, although previous studies have actually noted that there may be a decrease in hyperactivity by age. So I think more work needs to be done here to really understand how those hyperactive behaviors may change over time, and who do they tend to increase for versus those where they may decrease. So those are some things that we need to understand a little bit better. But we can talk about it anyway. Case study.
Yes, so let's talk about Nora. Nora's a 7-year-old. She has a UBE3A mutation as her cause for Angelman. Nora has always been an extremely busy kid, constant need to move and explore. She is super social and is very distracted by social interactions and social bids, but she just is interested in everything. She will just go through everything in any environment, all of the drawers, all of the she'll get into everywhere. She's got, her dad describes as sort of a destructive curiosity. It's not trying to destroy anything, but she'll take everything apart to curiosity. And she's very easily excited with social interaction, with sort of more forceful social interaction, kind of like a big exciting environment. She can get very giddy. Now she's on the floor and she is rolling around laughing, and we have a real problem on our hands. So this happens more when there's less structure for her, and this sort of limit testing silliness can make it very hard to get her back on task during therapies. In fact, really, it's hard to get her to focus for anything longer than a minute. And that's really slowed her progress with speech therapy, the usage of communication assist devices, any sort of work on her activities of daily living, and makes it very hard for her to make progress in school.
Okay, so talking about some behavioral approaches here, anytime we can, and we know that sleep is challenging for Angelman syndrome, but certainly having lack of sleep can cause increased hyperactivity. So wherever we can, addressing the sleep issues may result in reductions in hyperactivity. And in the inverse, getting more exercise, so more opportunities to do things that actually increase the individual's movements and sort of wear them out in some ways, so that we see some of the hyperactive behaviors decrease. And then there's some educational interventions, making sure that there are enough breaks that are scheduled within a short period of time where the individual is or Nora is being asked to do something. So it may only be that she has to stay on task for a minute and then she gets a break. And then the next week we're going to go for 2 minutes. And then we build that up so that she has longer and longer periods of time in which she's engaged with the breaks in between. Lots of praise for every time the individual is able to extend that amount of attention and reduce the hyperactive behavior. There's also, strategies around, especially when we hear about Nora having greater or increased hyperactivity when there's less structure. So making sure that there is enough structure within her day so that there isn't a whole lot of downtime where she may be engaging in grabbing things and getting into things. And then making sure that when we do see some of the ramping up of silliness, that isn't reinforced, because that is a high danger with individuals with Angelman, because they can be very sweet and cute and engaging and trying to get you to be silly and laugh with them. And then the second we start laughing and engaging with them in that way, that becomes a reinforced behavior and we might see it increase. So being able to sort of work back up a little bit, and engage in the silliness and the fun and the play when she's actually been able to show some attention and focus. We also want to make sure that with the hyperactivity that we are taking precautions around the individual running away. So we can see higher chances of elopement where they're wandering off. So we need to make sure that we have strategies in place to reduce that and make sure that the individual is staying where they need to stay. Similarly, when you have increased hyperactivity, in addition to motor challenges, motor planning challenges, there's a higher risk of falls and injury. And so we want to make sure that we have the strategies in place to help her calm down and reduce elopement and fall risks. And so as we've been talking about with all of our behavioral strategies, again, having calming sensory interventions, things that an OT can recommend that are specific for hyperactive behaviors that can help reduce some of those behaviors and give another channel for that energy versus getting into everything around them. And similarly, things like the chewy tubes, things to put in their mouths, things to fidget with in their hands, having a whole bag of toys that they can go through, that's their calming or active energy reducing bag of toys can really be helpful to just cycle through those types of things to keep them engaged.
It's for traditional ADHD, oftentimes the starting treatment would be a stimulant medication like Focalin or Adderall after you've tried school interventions. However, it appears that these type of medications, at least in my own experience, are more likely to cause side effects. So oftentimes, if I'm thinking about getting to the point of considering a medication for hyperactivity or severe impulsivity, where these behavioral interventions that Dr. Wheeler is talking about are not really helping, I'll oftentimes start with thinking about a non-stimulant medicine. And these are medications called like guanfacine or clonidine. They're called alpha-2 agonists, and essentially they're kind of similar to propranolol that I told you about. They do a little bit of the opposite of the fight or flight response. They're sort of calming after you take them. The real problem is that they can cause some fatigue. They can sometimes exacerbate constipation. Oftentimes, a very small dosage is all that's required. Many families I work with a compounding pharmacy to give really small dosages of this medicine to allow it to be more tolerable. But these medicines, they can be quite helpful. And it's just important to think about medicines like Adderall, stimulants, Ritalin, Focalin, and think about those with caution. Those probably are not first-line treatments. Next point here. Atomoxetine, which is Strattera, is a medicine that needs to be swallowed. They recently came out with a viloxazine, which is a non-swallowable version of this. Don't have a lot of experience yet working in Angelman, but this is a common treatment for hyperactivity as well, and maybe worth considering. Next point. We've had some people have collaborated with that have worked with people with Angelman syndrome that found some improvement with typical anti-anxiety medications. Next point. And then in cases where there's also severe aggression, risperidone and aripiprazole, like I mentioned before, can be a 2 birds with 1 stone treatment for this issue, because these medicines can also help with hyperactivity. Next point.
Okay, and now we'll talk a little bit more about sleep, which we've alluded to being a challenge that can exacerbate some of the behaviors, but it can be a problem in itself. So we know that individuals with Angelman syndrome have a high lifetime rate of having sleep challenges. There's a high percentage of individuals that are reported to have difficulties, whereas it had been previously thought to be like one of the key phenotypes or key challenges in Angelman syndrome. We are finding that there is a minority of individuals with Angelman syndrome that actually don't have any sleep challenges. So I think that's an important thing that we need to be talking about. The sleep issues are most prevalent during the early childhood phase, but for some individuals that may persist longer term. So just some examples of the challenges that we hear about in terms of sleep. The majority of individuals who are reported to have sleep challenges have difficulty initiating sleep, so falling asleep at the beginning. And then about 66% have difficulty staying asleep. So once they fall asleep, they may fall asleep for a few hours and then they're up and then that's it. So that's a very common sleep routine that we hear. And then about half of the individuals just report having a reduced amount of sleep. So even though they may sleep, quote unquote, through the night, it's not really enough sleep to provide the rest that they need to potentially have an impact on behavioral issues. So just some data from the most recent natural history study. So we see a higher rate of sleep problems in individuals with UPD than the other groups, although you can see these are difficult. The difficulties are high across all of our subtypes. And the onset of sleep challenges is very young. So this is, in the very infancy stage that we're hearing about having some trouble with sleep. And sleep latency is basically the amount of time it takes for an individual to fall asleep when they first go to sleep. So, we're talking about 20 to 30 minutes on average across the groups, which isn't horrible, but then you can see a high percentage of individuals are waking up during the night and staying up. And so that's where we really hear about and see a lot of the challenges that families report with sleep. So.
All right, so Calvin, our last case, 14-year-old boy, has Angelman syndrome via maternal deletion. And Calvin did great with his sleep for a long period of time, all needed just like a small dosage of melatonin, no problems of sleep initiation or maintenance, through sleeping through. And then the pandemic hit. And then it was a terrible situation for Calvin. There was like, that first initial year and a half where he couldn't go to school. He got a lot more attached to mom and dad and spending time with them consistently. And around that time, Calvin really seemed to struggle a lot more with separating from mom and dad at night. Now, all of a sudden, when they could kiss him on the head and say goodnight and walk out, it's taking hours for him to fall asleep. And he is getting agitated whenever mom and dad leave the room and then getting himself worked up. And now he's up for hours. And if he wakes up at the middle of the night, there's a tantrum if parents are not present. So now parents need to go in, and once they're in, Calvin's excited to see them, and he's awake, and he's up now for an hour. So what used to be great sleep is now a major problem for Calvin. Next slide. I'll just continue to talk a little bit more here. There was a really important trial that came out this year by a group that studied behavioral interventions and found that even in this trial, older kids and teenagers could still potentially benefit from behavioral treatments. The reason why behavioral treatments play such a foundational role aren't helpful for everyone, but with sleep issues at night, because a lot of the challenges with sleep have to do with the separation challenge and a need for the parents to be present, or for caregivers to be present in order to be able to fall asleep, to develop what's called a sleep onset association with parents or grandparents or caregivers or whoever it is. So needing for them to be there as part of the usual things, whether it's a teddy bear or a preferred blanket or things like that, parents kind of become the sleep onset association. And now, for the little waking up at night that all of us may have sometimes, or are more common in Angelman because of perhaps incontinence at night, now, because they're used to the parents being there when they fall asleep, they need the parents to be there if they have those little wake ups at night. And they're not used to or able to be in the bed alone. They're really not used to that. They're not comfortable with that. So there are ways in which the challenges with sleep onset association at the beginning of the night, if not addressed, can exacerbate wake ups in the middle of the night. And these contribute to probably biological reasons why sleep is harder in Angelman, or things like, incontinence, or not being having accidents at night, which also make it harder. So behavioral interventions can really help, even though we think about sleep problems as being very synonymous with Angelman syndrome. And so in this particular study, they did a couple of behavioral interventions and found that there was a real improvement in both how long it took to fall asleep and then how long those late night wake-ups were with behavioral interventions. And some of the strategies they tried included bedtime fading. This is actually counterintuitively moving back the bedtime so that kids and adults are more sleepy when they actually go to sleep, making it a little bit easier to do that separation because they're already zonked and they're a little bit less likely to put up a fight. And then you may have a bedtime that's really late, which is not acceptable, but once they're used to falling asleep alone because they're so tired, you start to inch up that bedtime by 10, 15 minutes every week or so until you get back to a reasonable bedtime. The excuse me drill, I'll just call out here as well. This is for a situation where there's co-sleeping, where the parent who's co-sleeping in the child's bed may say, they go through the nighttime routine. All right, good night, we're going to bed. And they say, oh, I forgot something, I'll be right back. And then they're gone for like 5 seconds tops. And then they come back and like, you waited, way to go, you did great. I'm so proud of you. You stayed here in your bed. Way to go, high five. And then extend that length of time that you're gone for little by little, making it longer, 10 seconds and then 15 seconds and then 30 seconds and then a minute. And so this behavioral intervention plus bedtime fading plus connecting with a behavioral clinician to, tweak those if they weren't really working, made a difference in helping kids with sleep as compared to people who are on a wait list. So those are some behavioral interventions to think about. Oftentimes you got to do it with the help of a behavioral clinician to kind of really, because it can be tricky in Angelman syndrome. But next slide. For some people, that's not enough. Before we talk about medicines, consistency with bedtime, a quiet, cool sleep environment in the summertime. Sleep gets worse because it's hotter in bedrooms, and it's daytime later, so blackout curtains. All these things can make a big difference. For some individuals with Angelman syndrome, it's just like they need less sleep. And so it becomes about training the person with Angelman, getting them comfortable with being in their bed alone, and a veil bed, a safe, protected, sleep safe bed or something like that, where they stay inside their bed, or making sure just the room is safe, with a camera in there to observe it to make sure it's a safe environment. It's really about just getting them comfortable with being in the bedroom on their own, even though they might get a little bit less sleep than other people in the house. All right, next slide. And then I'll just finish talking about medications here. So there was a randomized placebo-controlled trial of melatonin, and it found that it helped people in this trial. Melatonin is not enough for some individuals with Angelman syndrome, but it can really help, and it's a good place to start. We're not aware of any long-term side effects related to melatonin. It doesn't seem to hurt the body's natural melatonin system, which is the natural hormone that in all of our bodies gives us the signal that it's time to sleep. It doesn't look like it affects the natural melatonin system. So it can oftentimes be a very reasonable, safe intervention to start. Next point here. Clonidine, and next point here, next one, trazodone. These were some of the most common sleep medications used in Angelman syndrome in a study that we did when we asked families what made a difference and what helped. And clonidine and trazodone were the medicines that families with a loved one with Angelman syndrome were most likely to stick with because they helped and they were well tolerated. Clonidine helpful for falling asleep, trazodone helpful for sustained sleep at night. Next point here. Mirtazapine, there was a case series done by Dr. Dewis's group that showed improvement in falling asleep with mirtazapine, which is Remeron. You have to watch for weight gain, but weight gain is good for some people with Angelman syndrome who may be quite thin. So that can be a two birds with one stone situation. Next point here. And then quetiapine is an antipsychotic medication I talked about earlier, used for management of aggression and irritability in severe cases, but at lower dosages, it can be very helpful for sleep at night. You just have to watch for all those side effects I talked about, increased appetite, movement side effects, muscle twitches, things like that. So the lower the dosage, and consider these behavioral interventions and other medicines before that, but it can very much work.
Okay, this is our last formal slide, and this is just, you've heard a lot about the work. Some of what we've talked about today has come directly from research studies that one or all three of us have been involved in leading. But a lot of what we've talked about today has come directly from our clinical experience working with patients with Angelman syndrome. And we want to be able to describe this even better than we have up to this point. And we want to know from you all, from parents, what actually has worked. And so we will be initiating a study in the next few months where we're really going to try to dig into this. And we want to hear from you all about your experiences. And so there will be two opportunities to participate. One will be interviews with the team to understand a little bit about what challenging behaviors you see in your loved one with Angelman syndrome, how certain measures that we use to try to describe behavior in Angelman syndrome work really, do they really reflect your experiences? And how could we change them to really be better at reflecting that? And we also want to hear from you what has worked, what strategies, what medications have you found to be successful for addressing some of these behaviors so that we can make even better guidance for future generations of kids and families who may need this, and for obvious individuals currently who are struggling with these challenges. And then after those interviews, we will be taking that information and putting it all together to develop a survey where we'll ask even more families to tell us about their experiences through a questionnaire. So again, two opportunities to participate. We will be reaching out to the community directly once we have the study up and going. But if you want to participate, please feel free to reach out to me, and we'll get you information and on the list to participate. So thank you all very much.
Thank you all for your time today. And if you have any questions, feel free to reach out and email us. Thank you. Have a good day.